our health without having to get it out of the pocket, out of pocket expenditure to cover our health bills. How do we get out of that, and how can this be fast-tracked and put into a policy where we can all access medical health at affordable rates? In studios to talk about that and break that down for us. So for us to understand why it's very important to have this conversation is Mr. Mugabwa Robert, the national trainer at Uwezo Twaweza. Yes. Welcome to the show.
Thank you so much.
Uwezo Twaweza?
Yes, Uwezo Twaweza, we can make things happen. We have capability. And this is just an organization across East Africa that always looks at the voices of the people. We go down and try to gather what other people saying. So under our different programs called Sauti za Wananchi, we carry out different research, and we ask citizens to comment on different issues. And over from the last year when we launched Sauti za Wananchi in Uganda, we asked the citizens to comment on what is the most pressing issue you are facing as a citizen. And I'm glad that today we are talking about health, because 51% said, we have an issue with health. And why? Because many times we find it hard to realize that the issue of money and expenditure on health is great. And in our different calls for research in Sauti za Wananchi, we found out that 51% of Ugandans visit government health facilities. And that speaks volumes of words. Then 28% go to missionary or NGO facilities. So here we have a bulk of like 79% of Ugandans are going out to government and these missionary hospitals, and they are spending.
Right.
They are spending heavily in either of those kind of facilities.
But government would come to its defense and say that, you know what, we actually put in a policy where access to healthcare in the government, you know, health facilities is totally free.
True.
So after all, we're doing something to cater for the people.
True.
So why isn't that not working out? Because just the other day, I was having a conversation with one of my friends. Unfortunately, he was involved in an accident, and he was telling me that he had to take, fortunately he wasn't hurt, but the person who was involved in the accident with needed to get health attention immediately. Now, on getting to the nearest government health hospital, he was told you have to buy the gloves, you have to buy every single basic facility for us to be able to work with this person. So if the government actually, you know, did this in goodwill, just to ensure that every single Ugandan accesses healthcare, and maybe that time they thought it would be quality healthcare, why has it not worked out for us?
It's hard to answer for government why things have taken this long, because as you mentioned earlier that it's long overdue. This health insurance scheme was introduced very many years ago. But as you've mentioned that there is nothing free, even in the government health facilities. In some way or the other, they'll ask you to contribute. And if you look at the amount of money you can contribute as an individual, if we had a scheme, it would be a little bit lower. Because if you ask for gloves, then assuming there is a power then you have to get either a torch or something, a solar lantern or something of the sort. There is a cost to you being okay in a health facility. Now, the argument is, are our people having all these monies to pay for the personal health in the health facilities? And the answer is no. Why? Because when we carried out, we still asked the citizens, what's the most pressing issue you're faced with? And this was last year, around August to September. And they said, first and foremost, it's poverty. Now, if 28% of Ugandans mentioned poverty, there are very many other problems they mentioned. But the majority said, we have an issue. Our pockets are not that heavy. It means that even in the spending of the little resources, health will be one of them, and it won't be the magnitude they would want to spend. So the argument is, how can we pull these resources from the healthy people and those who are challenged with health, then from those who have money and those who are handed up? And that's why insurance as a scheme helps, that you collect in a pool to serve the issue of health. And because if, Robert, I can pay, let's say, 200,000 for health, and there is somebody who can just pay 30,000, so there is a figure that we can agree on as a nation. Say, no, let's pay this. Because even when I go to the public health facilities,
right,
I'm spending money, and which is a lot. So can we have a pool as a citizenry, and we fund our health?
Okay.
Yes.
So what you're saying is, at the end of the day, let's see what you can bring on the table.
Exactly.
It's not totally free. You won't get a health cover for free.
No.
You have to bring something on the
Exactly.
table. Just break it down for us, because the proposal was that amongst them that are actually employed, that the proposal was saying that if you're employed, be it by government or by private sector, you will have to deduct 4% of your monthly income to go to that particular pool, and then your employer to top it up with another 4%, so that makes it 8% per person. So if that actually is rolled out, how then do we measure up what the common person who is not in formal employment contributes to the pool? How can that be measured?
Ironically, in our survey still, we asked citizens who view is on insurance, and it's only 2% of the citizens that are on health insurance, according to our survey. And it so happens that
this
98,
is private health insurance.
And this is private health
Right.
insurance. So we only have 2%. And remember, these are those people that work in the formalized kind of sectors. Now, Uganda, recently you hosted the CEO of the registration bureau here, and the retirement benefit, and he told you that 2% is the formalized Uganda. Around 90% of Ugandans are in the informal sector.
Right.
So the challenge we have here is, how do we discuss with the informal sector of coming up with an amount? These issues of 4% of somebody's salary, it's discriminatory in a way. There must be just a figure, because if you are earning 1 million, why should you give us 4% and another one is earning 200,000, it's giving 4%? If you discuss the 4%, there will be an issue, but it can be a figure. Because recently, before the abolition of graduated tax, people knew that I have to pay such and such an amount as a citizen to help the public service. Now, what is so difficult to sit down as Ugandans and find out what figure can we put out?
A blanket figure?
It should be, because you see, when you look at other nations, Ghana, Rwanda, Kenya, fine, they are dealing with percentages but also with figures. In fact, we need to benchmark from these different entities to find out how are they going forward with this thing. Because the issue of percentage just per se can bring a lot of challenges.
Issues.
Why?
Right.
We have taxations that are on percentage. So if we also push health only on percentage, then I think we shall have a lot of debate in the House.
Okay.
Yeah.
So if we have a blanket figure for them that earn fairly enough, and them that earn not so enough, who struggle, who just earn and just eat from hand to mouth, will it be fair? Because I'm thinking, and I'm just borrowing this from our neighboring country, who was able, a country which has been able to do this. What they did for them that are employed in the formal sector, and this is Kenya, they had a blanket percentage.
Exactly.
Yeah, of course, if you're earning 200,000 per month and I'm earning maybe 50,000 per month, still it's 4%.
Exactly.
But my 4% won't be as much as
true,
yours.
true, you're right. Yeah, you're right,
and now,
right.
of course, they rolled out with that, and it's been amazing, because people will tell you, I had not not planned that my loved one would be admitted in hospital, but because of my contribution, now that insurance was able to actually cover X, Y, Z, and that really helped me, because it helps you for the, you know, for the worst days that you actually didn't foresee. Now, the conversation has been, okay, fine, the national health insurance is only covering them that are in the formal sector. How do we now bring on board them that are in the informal sector? And so what the government of Kenya did is, they said, okay, fine, we'll make sure that it's as comfortable as you can afford it. So for them that are in the informal sector, border riders, someone in the chibanda, anyone, you're told you can just give us 20 shillings of your daily income. Just put it there. Of course, it will add up by the day, by the month, and stuff like that, and you will get covered. That's 20 Kenya shillings, and here it's roughly, let's say, 600, 700 shillings per day, something everyone can afford. And so even them that are poor can now go get admitted to hospital, and your bed is covered, you know, basics are covered. And so it's really helped. So if we're to roll it out here, how then do we do it well enough such that even them that are in the informal sector don't feel like it's pinching hard on their daily income? Yes, I think you've raised it right, that the argument of percentage can work for the formalized kind of people, but the informal sector, the 98%, when you start on percentages, then you are going to run mad, because very many even can't tell you that in a month I earn this, because it keeps on oscillating. And having a benchmark for the informal sector is very beautiful. And we've had OTT, and it's at 200 per day. And I only wish we had that for health. I only wish we had that for health. And we know that anytime I walk into this health facility, I'm really, really covered. So the argument is, how can we, first of all, agree that we need this? Because the issue here is, probably we have people that are still debating in their mind that, do we really need this? But the figures show that a lot of things that are straining these households is on health. It's on health. And even when we asked them still further that, okay, when you visited, the last time you visited this health facility, what was your challenge? And the majority, which is 26, the majority told us, 30% told us that it's long lines and waiting. What does it mean? There are very many people at these health facilities waiting for that service. That free service. That free service, yes. So then the 29% told us lack of medicines. So if we are talking about the health insurance scheme, there are these things we need to deal with. Then 18% told us about lack of attention by the medical staff. And still 18% told us that it's expensive. So when you get to the top 5, that is long lines, lack of medicine, lack of attention, and then the cost. Because we asked them, okay, fine, you go to the public health. Why do you say it's expensive? But 18% told us, we can't afford. Right. So it's a cocktail of issues that we need to address. Wow, it's amazing, because now someone would just argue that the free policy on health services is not working for us, right? It can't work. Okay. There's also been issues, of course, with the African countries that have gone ahead of us and implemented the national health insurance. There's also been issues to do with corruption. True. It's a monster we have in this continent. Yeah. Exactly. So in terms of just making sure that this monies are put into the right, work and use, how best will that be addressed? Will this monies go into paying health attendants? Will this monies go into making sure that all the hospitals have medicine, basic equipment that we need? What should this money go to do? A pool of any public fund should be used to issues that need to be addressed as a whole. For example, infrastructure. Because if we are to have a very good health sector in this country, you can't run away from improving the infrastructure we have. And such pools of money are helping government to have a better budget on health.
And this must be deliberate by state, to say that this amount of money must go to infrastructure, must go to this, must go to staff, we must recruit more people. Then what the citizens are bringing is just helping us to keep the bus afloat. And many times people ask, okay, the corruption issue, it's deliberate. People are corrupt deliberately, and it's systemic. So if we are thinking of insurance, we need to get out of this rat race of corruption and say, fine, we either kill our citizens or we give them health. And anyone caught swindling the health money is killing the citizens. So there should be punitive measures, even in the policy. But already we have this. The issue is, can we implement this? Right. Can we implement this? So by and large, the issue of corruption, as you know it in Africa, we just have to deal with it, and we be bold in this. Yeah.
Right, right. And someone is actually asking on social media, if then this is actually implemented and we have the national health insurance policy, will it cover expenditures out of the country where someone has to maybe be taken to India, maybe for a kidney transplant or for cancer treatment? Does it help?
I think it's a challenge for our health sector to improve. And so as we can do whatever we need in this land. Why should you go to India, yet you can study medicine and be trained? Uganda has the best cardio surgeon in the world, but he's in Australia. So how can we tap into these people? How can we tap into skills? How can we bring the best kidney surgeon in the world to work here? So instead of having Ugandans fly, can we? It's a discussion of having the talent in here. Can we groom this talent? Uganda used to be the center of medicine across the region, whereby all experts, even up to now, if you go to South Africa and you're going to be operated on, you have a bone issue, they will say, wait, and here you will see some CHP coming. Right. So the issue here is we have the talent. Can we tap into that? Can we pay it so as it stays here than running to Botswana? Can we facilitate the best we have? And we have these services here. Because if you look at the cost of flying one to India, these are tens of thousands of dollars. Right. And the same money can be harnessed here. Absolutely. So the issue is, I doubt whether this scheme can cover you outside this country.
So it's just for within the country.
It's within, because I've not seen countries that can cover you outside there.
Yeah, because the rough figure, the cheapest kidney transplant that is provided in India costs roughly about 90 to 100 million Uganda shillings. That's a lot of money.
That's a lot of money.
Okay, once we embrace this and just escalate it to the next level, once we get it right, can this work where we have nations merged together such that my insurance health policy for Uganda can work for me maybe when I've traveled for work and I just fell ill, maybe in the neighboring country, for example, if I just go to Tanzania, I'm admitted because I'm ill, then that card that I have for my national insurance, me being a Ugandan, can actually work for me in Tanzania. Can that work?
I think that's the greatest challenge we have as the East African community. We've looked at various harmonization of policies, and I think this is now a challenge we have as a community to look at our health policies as a region. Then we see if all of the different citizenry in this region are paying health insurance. For example, 80% of Rwandans are covered.
Brilliant.
80%
That's a good number.
of Rwanda are covered. But in Ghana, it's 38% of population that is covered. In Kenya it's 12% that are holistically covered. So the challenge is fine. Uganda, we've not yet even started to work on this journey. Can we start? Can Burundi start? Can South Sudan start? So as when you say, wherever you go, you've gone to Juba to work, your health policy in Uganda can cover you. I think this is a good dream to fathom as a region, and it's possible, because if we have now no borders as a region, and now people can get employment across, you can invest across the borders. why is it hard for us to have a health issue?
Right.
Because many times you say, you've gone to Nairobi, you've gone to Aga Khan in Nairobi for treatment, which is brilliant, but can we have that? But it starts from all individual states to admit that this is something we need to harness. And it's from there that we can start the discussions of having the policy across.
Right, harmonization of these policies.
Exactly.
I'm sure you're always on ground.
Yes.
How did Rwanda get to that percentage? 80% of the entire population
covered.
Holistically covered?
I think Rwanda as a nation is deliberate at its policy. And they agreed to the baby steps. And they say, let's start with this bare minimum than pushing for a lot of money and you don't start. So in Uganda, we've had different districts piloted and trying to see how is this community-based health schemes. And the issue is, let's start. Rwanda reached the 80% because it started.
Right.
It started, it said, no, let's start. Let's give it a bare minimum and let's start. So they used the community-based approach. And the same to Ethiopia. Ethiopia is at around 10%. But Ethiopia, with its giant population, 10%, that's a good start.
Right.
That can be like 25%
and
in what we have here.
Ethiopia is actually one of the poorest African states.
Exactly.
So if they're 10%, really
exactly.
they're making good.
They're making progress.
Yeah.
And recently, since they allowed us to go there without any payment, so we are seeing at least they are walking the talk. And in Uganda, the challenges we are facing is that we have all this data, we have all these policies, we have all this thinking. Can we interact with the evidences and we start to do something for the citizens? Because for the citizens are crying loud. In Sauti za Wananchi, we are listening to these voices. Voices are coming out. Can we deal with the health issue?
Okay.
Yeah.
All right. And as we come to a close, just for us to still see how we can get the informal sector on board, because for the formal sector, it's pretty much direct because structures are there. So where do we start with the informal sector? Do we now start focusing on seeing how SACCOs will bring together people and they contribute as a whole, chamas, investment groups and stuff like that? How do we make sure that everyone just comes into this pool of togetherness such that we now harness on the ready structures that are there to make sure that this policy actually runs?
True. I think yes, we can look at the different groupings. The challenge in Uganda is that the cooperative spirit is now just growing. It fell down and now we are just reviving it. It would be easier there. But still, we have different sectors we can start with. For example, the border rider. A border rider, at the worst day you earn, let's say 10,000. And we are asking, can you contribute 300 shillings? To make sure that if you are knocked, you have a cover for you. And this must be deliberate with all kinds of groupings in this country. Meaning that the local governments have to come in to help, because they know who are these guys. Because at the national level, it might be a little bit of a challenge to understand who are these in the informal sector. For example, you have our mothers who are in the markets.
Right.
And these people, day to day, they are faced with the challenges at home. The child is sick, we have some little fever, and always they have to go to pharmacies. In fact, in our study, we found out that more people go to pharmacies to find to get health. So, can we help this informal sector? Yes. Can we talk to them? Can we show them that it is relevant to be covered? Can they experience it individually? Say, oh, last year I just needed a card. We are seeing these things happening in the issue of family planning. There are different NGOs that are having voucher card system. You have your 4,000 shilling, you pay, but you are covered for family planning.
Brilliant.
So, can we benchmark from these different organizations like Marriage Stops, like these different organizations that are doing it for family planning? What are they seeing? Are the people paying? And people are paying. So they are linked to the antenatal and post-antenatal care, and at a cost of 4,000, I would run for that.
Right.
I would run for that.
Right.
Yes.
So it's possible for us to actually execute.
Very possible.
But what people are saying on social media is that that can only happen if we are promised the service delivery will be improved.
Exactly.
Because there's no need of me getting my 700 shillings every single day and it doesn't translate.
And you go back to the long lines, you go back to no medicine, you go, no.
Exactly.
We have to improve that.
All right.
Yes.
Okay. Thank you so much for coming in studio.
It's a pleasure to always
Keep
be
your
here.
views coming. The hashtag is Morning at NTV. That's on Twitter. You can also stream us live and drop in your comments. NTV Uganda, that's on Facebook and YouTube pages. What are your views? Do you think that the health insurance policy, national health insurance policy, is actually long overdue? Would you contribute towards it? Are you in the formal, informal sector? What are your proposals for this? Very important. We need to get your views on that. The hashtag, like I said, is Morning at NTV. Thank you so much, Mr. Mugabwa Robert, national trainer, Uwezo Toweza. Thank you so much for coming.
It's a pleasure to be with you.
All right. Morning at NTV still continues. Up next is Reality on the Ground with Andrew Chamagero. Keep it here.
You're watching Morning at NTV.
Anya gange nze Mukye Patrick ndudde nga nkozesa ebidduka kakati nali mu mmotoka nga ntambula driver n'atuuka mu kkoona yali adduka nnyo teyasala ku misinde n'asanga emmotoka endala